Good evening, everyone. Assalamu alaikum. I would like to thank you all for joining us in the second day of ACR Convergence 2020 under umbrella of Saudi Society of Rheumatology. Today, it's my pleasure to introduce our session moderator, Dr. Muhammad Mudaffar. Dr. Mudaffar, he is an associate professor at King Abdulaziz University, Jeddah, and he is a pediatric rheumatology consultant who had his fellowship from Sick Kids Hospital in Toronto. Dr. Muhammad, you are welcome.
Thank you very much for the introduction. I would like to thank you and the organizing committee to give me this opportunity to moderate these sessions. And we have 3 speakers today, and all of these speakers are junior rheumatologists. I will start the first speaker, Dr. Al-Hanouf Al-Salim. She's a consultant of pediatric rheumatology at King Faisal Specialist Hospital and Research Center in Riyadh. She's certified with Pediatric Rheumatology Board, clinical fellowship at King Faisal Specialist Hospital in Riyadh, in Saudi Arabia. And then she did pediatric clinical fellowship at Hospital for Sick Children in Toronto in Canada. She has postdoctoral fellowship, translational autoinflammatory disease section specialty training, and she joined last year King Faisal Special Hospital as pediatric rheumatologist. And it's my pleasure to honor to introduce you this junior and incredible speaker, Dr. Al-Hanouf Al-Salim. She is going to talk today about new and autoinflammatory disorders. So please, Dr. Hanouf, start.
Assalamu alaikum. This is Hanouf Al-Salim, Pediatric Rheumatology at King Faisal Specialist Hospital in Riyadh. First, I would like to give special thanks to the organizing committee at the SSR for giving me the opportunity to present my talk, which will be about what's new in pediatric autoinflammatory disorders. This year, we'll be targeting lessons and updates learned from the ACR Convergence 2020, for which I would like to give an acknowledgement for the oral and the poster presenters this year, which a great data in the era of autoinflammatory diseases were presented. I have no disclosures, and my objectives will be addressing 4 important aspects, starting by describing new autoinflammatory diseases and probably talk a bit about the genotype and phenotype features, in addition to review the immunological characteristics underlying such conditions. Then we're going to move on to 2 important aspects, which I think most of us will be also interested in, to talk about the therapeutic strategies of these rare monogenic autoinflammatory diseases, and the updates about the long-term outcome and safety of biologics in monogenic autoinflammatory disease. So the first aspect is the newly discovered autoinflammatory diseases, starting by NEMO-NDAS. So what's NEMO-NDAS syndrome? It's an autoinflammatory diseases secondary to a mutation at the NEMO gene, which is also known as the IK-BK gene. This is a splice mutation targeting this gene, which play an important role in the NF-kappa B activation. NEMO-NDAS syndrome has an early onset disease as early as 2 days of life, and some of them they can present at 2 years of age. They do have some distinct clinical manifestations involving the ectodermal changes, as you can see here in this picture, the conical teeth, and skin manifestations involving nodular rashes and annular-like lesions, as you can see here in this picture. Their histopathological features includes neutrophilic panniculitis, and some of them have lymphocyte and histocytic features as well. Patients with NEMO-NDAS syndrome, they do have CNS manifestation, includes developmental delay, brain imaging finding with brain volume loss, and some of them they do have as well hematological related CNS disease as subdural hemorrhage. To understand the underlying immunological characteristics of such condition, the group from the TATS team at the NIH, they looked at the interferon score at the NEMO-NDAS patient, and they compared with other controls, specifically including the interferonopathies patients such as Candle syndrome and SAVI. What they found that the interferon score in NEMO-NDAS patient was kind of almost normal to low compared to the interferonopathies. So what they did is that they developed another score which targeted the NF-kappa B mediated disorder by assessing 3 important gene-related signatures, include the CXCL10, the GBP1, and the SOCS1. They defined a positive score if it's more than 0.15, and this is the data analysis of what I've been talking about. So this is a 3 out of 25 gene ratio to address the NF-kappa B mediated diseases. So the one in green and the one in orange dots are the NEMO-NDAS patients, and they compare to the interferonopathies patients, to NOMID, which is an IL-1 mediated disease, and healthy control. So you can see that there is a significant difference between the NEMO-NDAS patients and the control, which indicate that this is an NF-kappa B mediated disease. So when they looked at this group of patients, initially they failed to detect any pathogenic mutation using the whole exome sequencing, but using a Sanger sequencing, they were able to detect a splice site variance involving the NEMO gene, which, as I said, is known as the IKBK gene. And they were able to identify a cohort of 8 females who shared the gene mutation in NEMO and had some different variants. Now I'm going to move on to talk about another interesting syndrome called the VEXAS syndrome, which is abbreviation for vacuoles, E1 enzyme, X-linked autoinflammatory somatic syndrome. It seems to be quite of a long name, but it's really quite of an interesting. So this is a group of Dan Kastner and also at the NIH. They identified this syndrome using quite of an interesting approach. So they used a genotype-driven approach using Sanger sequencing rather than a clinical-related approach. And they identified the VEXAS syndrome, which is secondary to a mutation at the UBA1 gene, which is an enzyme encoding, which is an enzyme that plays an important role at the ubiquitination that participates in the protein folding and degradation. So by doing this interesting approach, they were able to identify a cohort of 25 patients. All of them were male, and their median age of onset was around 60 years old. So this is really an adult autoinflammatory disease. They shared kind of similar clinical characteristics, after all, in the form of recurrent fevers, cutaneous manifestations, as I show you in the previous picture here, where they have these tender plaques. They do have as well some pulmonary-related vasculitic changes, in addition to polychondritis, which is actually present in a good number of cohort of these patients, which is around 60% of them. They do have some hematological manifestations in the form of macrocytic anemia, and of course the myeloid dysbiosis, which was quite evident in this group of patients. Those patients, they do have as well a high inflammatory markers. And then when they assessed further the underlying cytokines, they identified that the VEXAS syndrome compared to control had an elevation in the interferon gamma, which probably indicate that this might be related to the interferon pathway. Still further studies, I'm sure, are ongoing to further understand the underlying pathophysiology of this interesting syndrome. So I'm going to move on to talk about another interesting condition, which is also associated with pulmonary disease, known as the IL-18 PAPMAS. This is an interleukin-18 pulmonary alveolar proteinosis and recurrent macrophage activation syndrome. There was a total of 8 patients identified with IL-18 PAPMAS, and actually I was part of this project. So all of these 8 patients shared some clinical characteristics in the form of recurrent fevers and skin rashes, whether urticaria or maculopapular rash. Around 2 patients met the ILAR criteria for systemic juvenile idiopathic arthritis. All of the patients share clinical characteristics with digital clubbing involving the upper and the lower limbs. They do have a final diagnosis of pulmonary alveolar proteinosis, which is one of the main findings in this group of patients. This was evident by radiological findings, as you can see here, and some of them even by histology with lung biopsy taken from them. The interesting thing about this group of patients is the significant elevations of IL-18. So you can see here in this patient, he had a total IL-18 of more than 400,000. This is quite a tremendous level that's been reported in the literature. And this has been evident here when we compared the IL-18 level, when we compared the IL-18 level in the serum, then we compare it with NLRC4 MAS, which is another known macrophage activation syndrome related to the NLRC4 gain of function gene. And we compare it with the interferonopathies and healthy controls. So there is a significant elevation of IL-18 in the IL-18 PAP-MAS and NLRC4 compared to the controls. The interesting thing about this group of patients is that when we measured the IL-18 in the lung, there was a concentrated high elevation of IL-18 and free IL-18 in the lung of a PAP-MAS patient compared to SAVI, which is an interferon, and sarcoidosis, which is a granulomatous disease. This kind of gives us a clue that this is probably what's happening in the lung in those patients might be related to the IL-18. And we did some further analysis by checking for cellular infiltration in this group of patients. We compared to SAVI and controls, and we found that IL-18 PAP-MAS patients had a concentration of alveolar macrophages and neutrophils compared to the controls. Now I'm going to move on to talk about another aspect of my talk, which is the long-term follow-up of these rare monogenic autoinflammatory diseases, starting with SAVI, which is a sting-associated vasculitis with onset of infancy. So most of us know that SAVI is one of the interferonopathies, kind of well-reported disease associated or actually characterized by vascular inflammation, cutaneous and interstitial lung disease. So in this abstract, they collected a total of 80 patients, 24 were from the NIH cohort, and the rest of them were from other centers, and some others were already reported in the literature. What they found is that the majority of the SAVI patient had early onset disease, less than 2 years old, and they addressed different clinical manifestations in this interesting rare disease. And they found that more than 70% of the patient had cutaneous followed by lung disease, respectively. Other interesting finding was the presence of O2 antibodies in more than almost actually 70% of the patients, in addition to MSK findings in the form of arthritis and myositis. What they were able to come out with is that the diagnosis of SAVI doesn't really require the presence of skin manifestation. And why this has been brought up is that because previously the diagnosis of SAVI did require the presence of cutaneous, lung, and of course the genetic mutation. They were able also to identify some distinct variants that plays an important role in disease manifestation. As you can see here, the V155M has been associated with severe lung disease and significant elevation in the inflammatory markers, whereas another variant such as the N154S associated actually with a severe lung disease in the form of tissue loss and an early onset disease as early as 1 month of age. Another interesting syndrome known as neonatal onset multisystem inflammatory disease has been also targeted this year in the ACR. So in this abstract, they followed a group of patients of more than 40 patients over a period of 15 years, and they evaluated those patients for an improvement or actually a remission in their inflammatory markers, the impact in their social and psychological status. So as I said, a total of 41 patients were identified. You can see here in this table that all of them had a mutation in the NLRP3, and 7 of them had a somatic mutation. The median age at enrollment was around 21 years old, and the age at the treatment initiation, which was an IL-1 inhibitor, was around 7 years of age. So they found that more than 90% of the patients actually reached remission with adjustment of the dose of anakinra, and more than 50% of them reach a dose of 5 milligram per kilogram. You can see here that around 20% of the patients, they were changed to Canakinumab. Unfortunately, more than half of them, they were back to anakinra for worsening and progressive headaches. So probably here I'm going to point out to a paper that was published 2 years ago by the same team, which is the TADS team at the NIH. They addressed the CSF analysis of short and long-acting IL-1 inhibitor, which is anakinra and canakinumab, respectively. And what they found is some of the patients who switched from anakinra to canakinumab had worsening CNS-related manifestations, specifically in the form of headaches. When they assessed their CSF findings, they found a significant elevation in IL-1 beta when they were on Canakinumab. Now I'm going to move on to talk about further of this cohort. In terms of further comorbidities, more than 60% of the patients of NOMID had persistent chronic headaches, and around 48% of them had progression of their hearing loss. Otherwise, in terms of their metabolic outcome, around 20% of them were obese, and more than 20% of them had hypertension. One of the most important findings that we target and we'd love to look at is the drug safety. So around 30% of the patients had skin-related infections in the form of cellulitis and pustular acne. This is really a very interesting abstract that I think most of us has been looking at what's happening to those patients in terms of long-term outcome and what will be the side effects by giving them IL-1 inhibitor for such a long period. Now we're moving on to talk about therapies and treatment strategies in autoinflammatory diseases. And we're going to start by a very interesting rare syndrome called COPA, which is a monogenic immune dysregulatory disease with severe interstitial lung disease. So what's COPA? It's, as I said, it's an immunodysregulatory disease secondary to a mutation at the alpha subunit complex of the coautomer subunit. This group from Boston, they collected around 11 patients with a final confirmed diagnosis of COPA patients, and they evaluated these patients pre and post starting them on rituximab. So what they found is that most of the patients, actually all of them were pediatric age group, more than 5 years of old, and all of them carry the pathogenic mutation in the COPA syndrome, mainly at the R233H variant. And they assessed their patients' response for rituximab. So what they found is that there was a significant improvement with almost back to normal oxygen requirements and an improvement in their radiological findings. This is an interesting figure when they compared the CT chest before and after starting them on rituximab. So you can see here that there is almost a complete resolution of the interstitial lung findings after starting Ritux. So they concluded that probably Ritux might be an important or play an important role in the treatment of such condition. So this is really kind of very promising results, but probably some further evidence and analysis and further details needed to validate this result. Moving on to another interested and challenging actually group of disease called the undifferentiated systemic autoinflammatory diseases, which probably most of us face in the clinic when we have these group of autoinflammatory diseases whom we fail to have a genetic pathogenic mutation. So they collected a total of 75 patients. More than 70% of them had a genetic mutation with no final diagnosis. Around 20% of them had a heterozygous mutation in the MEFV gene. They treated these patients with colchicine and they followed them for a minimum of 3 months follow-up. And they defined a complete response by resolution of disease, partial response by decreasing of the frequency and the severity of the manifestations, and a response by no change of the disease itself. So they did their analysis by comparing the relationship of the demographic data and the clinical manifestations with the treatment response. So what we can see here and what they came out with is that more than half of the patient had complete and partial response in 47% respectively, whereas around 9% only didn't show response to colchicine. One of the poor clear predictors, as you can see here in this table, is the presence of oral and genital ulcers, which was statistically significant that patients with ulcers failed to respond to colchicine. Whereas other demographic they come out with is that the female gender and the European ethnicities as well, they do show some poor predictors and response to colchicine. Whereas, as you can see here in this table, the GI manifestations, specifically vomiting and lymphadenopathy, probably show some good predictors, and it was statistically significant for the presence of vomiting. Moving on to my last aspect, which is talking about the long-term outcome and safety of biologics in monogenic autoinflammatory diseases. starting by this big project where they target the effectiveness of Canakinumab in monogenic autoinflammatory diseases. So this is an open label, long-term perspective, multicenter study. They collected patients who had a final diagnosis of CAPS, FMF, or tumor necrosis factor receptor associated periodic syndrome, known as TRAPS, or hyper-IgD syndrome, which is also known as Macrophage syndrome. Their project plan is to enroll 300 patients who are 2 years of age and older, and they are treated with Canakinumab. In the ACR this year, they presented the first interim analysis from this registry, but they only included the CAPS patients, which is around 80 patients. Those patients were treated, as I said, with Canakinumab, a dose of 2 to 8 milligram per kilo every 8 weeks through a subcutaneous injection. And then they assessed the outcome for effectiveness using some of the outcome measures for the physician and the patients and the inflammatory markers in addition to the hearing assessment. Of course, a safety of a drug was also assessed. So what they came out with is that in regard to the physician global assessment, there was a persistent, sustained, mild to moderate clinical disease activity among the follow-up, whereas the inflammatory markers, as you can see here, we targeted the CD-active protein and the serum amyloid was kind of stable throughout the follow-up. In regard to the hearing loss, there have been unchanged analysis since the baseline till the 18-month follow-up with unchanged persistent sensory neuron hearing loss. In terms of the patient outcome measures, most of the patient reported low fatigue scores in regard to their disease, and there wasn't really that huge impact on their social life. Otherwise, in terms of the adverse events, there wasn't really that significant newly identified adverse event. Apart from that, infection remained one of the most common side effects. Serious events were identified in around 13% of the patients. In the last couple of slides, I'll talk about the JAK inhibitors and the risk of infection. As most of us know, JAK inhibitor has kind of targeted in interferonopathies related diseases. So in this abstract, they collected a total of 23 patients with interferonopathies, and they treated them with baricitinib, a dose of 0.3 to 0.4 milligram per kilogram per day. So, and then they assessed the patient in terms of the frequency of the BK virus infection, whether in the blood and the urine, over a period of 3 to 4 years. So what they came out with is that there was a total of 10 candle patients, 7 SAVI, and 8 other interferonopathies related diseases. So what you can see here is that more than 80% of the patients had actually positive BK infection in the urine, and around 60% of the patients had BK infection in the blood. When they did further analysis to assess if the disease subgroups played a role, there wasn't really that big difference, but another analysis to assess the dose itself of the baricitinib, whether it has a relationship with the improvement of the BK titers, as you can see here in this graph, there was actually a significant difference. So you can see here whenever the dose has been tapered down, there is also a decrease in the BK viral load by going down to 0.3 milligram to less than actually 0.3 milligram per kilogram. There was also a drop in the BK viral load. So from this, there's kind of a message they came out with is that a dose adjustment and maintaining the lowest therapeutic dose has really a big role in maintaining a low to negative BK viral load. By this, I'm going to end my talk by giving a special thanks to Prof. Al-Mayouf for all of his support and advices through the years. And thank you.
ايوه يا دكتوره هانو، لسه باقي 5 دقائق عشان تنتهي محاضرتي.
5 دقائق؟
ايوه. Oh, you just finished.
We are live right.
Thank you, Dr. Hanov. Finishing before time, 5 minutes. You have still to go to finish, so we have plenty of time for discussions. It's very comprehensive and interesting review of this new topics, which is considered the hot topics in pediatric rheumatology, autoinflammatory disease. And actually, we are still learning new. You are presenting a new disease, so still we are in the process of learning, and we learn a lot from your lecture today. And I'd like to give a strong message to the audience. This autoinflammatory disease takes a long time for diagnosis, but as you know, in our country, people do not follow one physician. Whenever they find that this physician did not give them what they want, they keep changing from one doctor to other doctors. So what will be your message overall to these patients who present with unusual presentation of lung disease or skin manifestation? Most of these patients present with unusual lung involvement or skin manifestations. Yeah. So this patient maybe undergoes many differential diagnoses and treatment and lab tests, including maybe even pulmonary lung biopsy. So in order to avoid extensive workup unnecessary, what will be your message to our audience?
I think, Victor, as I said, plenty of these diseases in the autoinflammatory era are kind of new in our practice. Some of them even have been discovered in the last couple of years. Most of these diseases, they do share, as you said, some clinical manifestations. The diagnosis of them is really quite difficult, but there are still some clues in each of these syndromes that can kind of pointing to what exactly you're dealing with. Again, as I said, some of these disorders, they're not even monogenic. They're kind of sharing some different candidate genes. Some of them share some immunodysregulatory kind of mechanisms. So the clinical presentation itself, with the associations of the symptoms, with the age of onset, the family history, all of these can kind of give you some clue about what you're dealing with. Definitely genetic would always be the main diagnostic tool, but I know in some of the centers we do lack the access for genetic studies, but unfortunately it's the main diagnostic tool we have.
I know that most of these patients are mainly diagnosed genetically. And for the time being, only few centers or one or two centers in Saudi Arabia, maybe they are able to diagnose genetically these patients. So,
if you allow me, Doctor, some of even centers, because of the lack of the access of the whole exome sequencing, let's say, they do have certain panels in order to diagnose these autoinflammatory syndromes. So what they do is that they kind of collect what will be the most common genetic mutations and put it in a panel, which will be cheaper and easier to access as well. But again, most of our centers here, we don't have the access of such tool.
Still looking at some questions from the audience. Let me ask you a few more questions. If this patient has genetic disorder, what will be your message to parents about next suspected pregnancies? Are they going to have more children with disorders, or it's just a mutation in the genes? How do you convince them that it's not a hereditary?
Yeah, that's really a very good question, because taking care of the patient parents and the family acceptance of their conditions is quite important. So as you saw in my previous slides, and especially with these novel diseases, some of them are de novo mutations. So in order to say that future kids may have the similar conditions, it's quite difficult. But let's be more general kind of thing, and we talk about the known monogenic diseases with autosomal dominant, autosomal recessive inheritance, and definitely the kind of inheritance in such conditions with a risk of 25 versus 50% in other siblings. So we do tell the parents that yes, for the known autosomal dominant recessive diseases, we know what will be the risk for the future kids, but for the de novo mutations, we don't really know, but we definitely prefer to, and that's what we tell the families, that for future kids, we definitely want to see them early to let us know earlier if they have any kind of symptoms, and make them kind of unaware what will be the clinical presentation, just to avoid kind of some of these morbidities and mortalities.
Okay, I have one question. They would like to thank you for an excellent talk. The question is still to confirm the diagnosis. What is your treatment advice?
So That's maybe more of a wide, broad question. Treatment advice will be depending on what you're dealing with. So, what exactly the autoinflammatory condition you're dealing with, you're going to target that pathway because the autoinflammatory diseases, they do have different genes, so it will be underlying different pathogenic immunological dysregulations, and you will be targeting that kind of immune pathway in treating. So, for example, broadly, interferonopathies, we treat them with JAK inhibitors most of the times. And for other conditions such as familial Mediterranean fevers, but I'm not going to go over all of the diseases. We treat them with different pathway. Definitely, there's the IL-1 mediated diseases. We treat them with IL-1 inhibitors such as the anakinra and canakinumab. So it's really depending on what you're dealing with, and you're going to target that pathway.
So if you don't have the genetic test, we can start one of the biologics at a trial on high suspicion before genetic diagnosis.
Which biologic you mean, Doctor?
I mean, like interleukin-1, Anakinra, or Canakinumab.
Okay, so this is a good question. You know, Doctor, maybe some of the IL-1 mediated diseases, such as the CAPS, let's say, some of them we diagnose them, even we lack the genetic mutation. And we know that this has been ongoing, and people from European countries have even validated the criteria to diagnose these patients without genetic mutations. So yes, the answer is that we do treat them with IL-1 inhibitors, even if we lack the gene diagnosis, because such conditions, we're kind of more aware about them and how do we diagnose them depending on the clinical manifestations. I would say that it's better to make sure about what you're dealing with first before starting those patients in biologics. If you are kind of sure about the diagnosis, then yes. If you're in doubt, then probably better to investigate further. Probably ask some people about this.
Okay, I have one more question. What serious or severe adverse events were reported with Canakinumab in the long-term study in your patients?
Yeah, probably I mentioned this kind of very briefly, just for the sake of time. There's a very good study that was published 2 years ago in 2018. At that time, they compared long-acting and short-acting, which is canakinumab and anakinra, respectively. So they compared these two drugs in CAPS patients in order to, specifically, I think it was in NOMID patients. They compared their CNS manifestations. And what they found is that the cytokines in the CSF, in addition, of course, to the clinical manifestation, was worse with the canakinumab versus the anakinra. And some of them, and I think the percentage was around 30 to 40%, were back to anakinra because of the worsening headaches and the elevations of IL-1 beta and their CSF. So probably canakinumab may not be the best option for CNS-mediated disease and autoinflammatory condition. But still, the evidence is not really that big. It's been only depending on few studies, and this was one of the biggest study addressing that point. I'll be happy to share it if there's a way.
Okay, one more question before the time is finished. They said before genetic testing, did you think some of previous reported lung manifestation in systemic GIA cases could be SAVI disease, which misdiagnosed due to lack of genetic test?
I know that probably people have been kind of in between now, between these autoinflammatory diseases and sharing the common manifestations. But I think SAVI and systemic GIA lung disease is probably quite different. Systemic GIA patients, they do have more of different manifestations compared to SAVI. SAVI patients, they mainly present with vasculitic kind lesions, whereas systemic GIA, we do know that they don't have these kind of vasculitic kind of involvement. So I think the comparison between them is quite abroad. Probably if you ask if the questions was more of what will be the pulmonary manifestations associated with systemic GIA, can this be the IL-18 path mass? Then probably the answer might be, we don't know, maybe yes. That will be depending on what exactly the lung involvement. But I think for SAVI and SGIA, will be quite difficult to compare between them because the two diseases are quite different.
Okay, since time is up, thank you very much for your great topic and great talk. And we are enjoying listening to your talk, really. Thank you very much.
Thank you so much, Victor.
Now we'll move for our new second speakers. Dr. Ghada As-Salmi. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, Dr. Ghada As-Salmi. I would like to introduce you our Dr. Ghada As-Salmi. She is professor and consultant of pediatric rheumatology at the Department of Pediatric King Faisal Specialist Hospital Research Center, and she's also professor of pediatric and consultant pediatric rheumatology at Faisal University College of Medicine. Our doctor will going to talk about the very hot topics nowadays in 2020, which is about pediatric COVID-19 hyperinflammation. I would like to welcome Dr. Ghada, and please start your talk.
Assalamu alaikum wa rahmatullahi wa barakatuh. I am Ghada Al-Salmi. I am a pediatric rheumatologist in King Faisal Specialist Hospital in Riyadh. First, I would like to thank the organizing committee for giving me this opportunity to present in the best of ACR. So my topic will be about pediatric COVID-19 hyperinflammation. Next slide, please. Next. So my objectives will be about mainly multisystem inflammatory syndrome in children. Brief, we'll talk about the pathophysiology, and just we will define some cases in multisystem inflammatory syndromes. We'll just go through the clinical presentation and similarity with Kawasaki disease and also the management. Next. So, brief, we'll talk about SARS-CoV-2. SARS is severe acute respiratory syndrome, coronavirus 2. The epidemic of SARS-CoV-2 causing COVID-19 has rapidly spread worldwide, as we all know. Italy was the first European country to be affected, with the outbreak estimated to have started in February 2020. In children, the respiratory involvement appears to have a more benign course, with almost no fatalities reported in this age group at that time. Next. So, shortly after the spread of SARS-CoV-2 to Bergamo, Italy, there was a 30-fold increased incidence of Kawasaki disease cases in pediatric. Children diagnosed after the SARS-CoV-2 epidemic began to show evidence of immune response to the virus, where older had a higher rate of cardiac involvement with the features of macrophage activation syndrome. Therefore, this showed that SARS-CoV-2 might cause a severe form of Kawasaki-like disease. Next. So in mid-April 2020, a cluster of cases were reported from the South Thames Refill Service in London. They noted 8 children who presented with signs of hyperinflammation and shock, with features similar to Kawasaki disease or toxic shock syndrome. 4 of these children had known family exposure to COVID-19, all tested negative for SARS-CoV-2 on bronchoalveolar lavage or nasopharyngeal aspirate. These children were noted to have abnormalities in cardiac function on echo, including coronary dilatation with giant coronary aneurysm. Next. So here is different articles, which we'll go through it during our presentation. Next. So the first cluster of cases highlighting what has since been termed multisystem inflammatory syndrome in children by the CDC, which is known MISC. So since the initial reporting, there was multiple cases cluster have been reported from different countries. And as of October 2020, there was 1,227 cases reported in the United States with a total of 20 deaths. Next. So just brief about the pathophysiology. So the main mechanism for MISC, it's by antibody enhancement, by increase the viral enter into the cell, or the alternative mechanism by which is believed to be related to cytokine storm mainly, and interferon gamma responses. And this also will lead to slow the viral clearance, and that lead to pronounced more inflammation. And also it's depend on some various protein like angiotensin converting enzyme and PIK3 and DAG, which is diglycerol enzyme. Next. So this is about the timing of MISC in related to COVID-19. So as we all know, it's almost when COVID-19 started in around February 2020, as we noticed here in the blue line. and it's reached its peak in the population. So around, we can notice here around March, the MISC cases started. So we can say around 4 weeks from the peak of COVID-19 SARS-CoV infection, MISC cases started to appear. Next. So just to talk about brief the case definition of pediatric inflammatory multisystem syndrome. As we can see, we have different organizations. We'll focus mainly about the CDC and the Royal College of Pediatric and Child Health. So for the CDC, we can define multisystem inflammatory syndrome in children, an individual less than 21 years of age who presented with fever more than 38 or subjective fever at least more than 24 hours, plus evidence of inflammation either by severe ill clinical manifestation required hospitalization or laboratory manifestation plus laboratory manifestation. So severe ill clinical manifestation that include more than 2 multi-organ system involvement, which include cardiac, renal, respiratory, gastro, dermatology, and the neurological manifestation. And other causes should be excluded. Those patients, they have one of the following lab. They have mainly high C-reactive protein, elevated level of procalcitonin, elevated level of ESR, elevated level of lactic acid dehydrogenase, and serum ferritin, and fibrinogen and D-dimer. Also, they have low lymphocyte count and low albumin. So all these patients, they should be tested. They should have recent infection or current infection with SARS-CoV-2, either PCR, serology, or antigen test. The other in the Royal College of Pediatric and Child Health. Also, they defined pediatric multisystem inflammatory syndrome, which is temporarily associated with COVID-19. They didn't specify the child age, but the median age was 10 years. And also they presented with fever plus clinical manifestation and evidence of inflammation, and not necessary to have SARS-CoV PCR infection. So that means around 1/3, we can notice around 1/3 of patients with SARS-CoV infection, they have positive PCR. But most of the patients, they have antibody tested positive. That means they have recent infection or 4 weeks prior to the symptom of MIC. Next. So this is the same. It's just only different schedule, or just to show the same definitions of MIC, but it have more detailed clinical manifestation. Next. So talk about clinical presentation of MIC. So almost around 80% of patients, they have pulpar conjunctivitis, they have red and cracked lip, cervical and mesenteric lymphadenitis, skin rash as well. Also, few patients, they have neurological manifestation, respiratory symptoms. A good number of patients have cardiac manifestation, including left ventricular dysfunction, coronary aneurysm, or coronary dilatation, as well as GI manifestation. Next. So here, just to elaborate more about the clinical manifestation, we'll concentrate mainly about the median age between 5 to 12 years. So we can notice in the first table that around 93% of patients between the age 5 to 12 years, they have GI manifestation. Around 60% or more than 70% of patients between 5 to 12 years, they have hematological manifestation. And also more than 72% of patients, they have respiratory manifestation, and around 35% from them, they have abnormal chest X-ray finding. Others, only few patients, around 3 to 4%, they have neurological manifestation. This all in the age between 5 to 12 years. Next. So here, just for the lab manifestation based on the age group, also between the 5 to 12 years, which is the median age to have MIC, they have, most of the patients, they have lymphocytopenia. They have also high neutrophil count. Also, they have high D-dimer level and high fibrinogen level. They have, most of them, they have low albumin. Also, a good percentage of them, around more than 80% they have high C-reactive protein, high serum ferritin, and also in addition, they might have increased troponin level in case of cardiac manifestation. In addition to the other manifestation, to the other lab like CBC, and including the hemoglobin and platelets and the other like coagulation factor. Next. So this is mainly about the cardiovascular outcomes in individual with MIC. So around more than almost all the patients, they should perform echo, and half of the patients, they might have abnormal echo, and they might have abnormal EKG, and this is especially in hospitalized patients. And we will talk about how frequent we should do these tests. So around 45% of the patient, they have depressed ejection fractions, and also around 8% they have aneurysm, and around 7% they have coronary dilatation, in addition to pericardial effusion plus pericarditis. And a few percent only of patients, they have mitral valve regurg. Next. So this is just to compare the sign and symptom in individuals with MIC versus COVID-19. So as we can see, so the MIC, which is highlighted in the yellow, it's most of the patients symptomatic around 100% compared to patients who had COVID-19. So almost all the patients, they had fever around 90%, they have diarrhea, they have vomiting, and they have skin rash, and also they have respiratory manifestation. We can see that COVID-19 patients, they have more respiratory manifestation than an MIC. Next. So the spectrum of clinical phenotypes or subphenotypes of MIC, in class 1, they have multi-organ involvement with shock, myocarditis, abdominal pain, high CRP, high serum ferritin, and the troponin level. In class 2, which we call it acute COVID-19, plus minus overlap with MIC. They have respiratory involvement, they have cough, shortness of breath, pneumonia, and ARDS, and this have the highest mortality group. In class 3, which is the less acute illness, and sometimes we call it Kawasaki disease in some patients. They are younger patients or younger age group. They have skin rash, mucocutaneous manifestation. They might fulfill the criteria for Kawasaki disease, and they have less organ involvement. Next. So the question is MIC similar to Kawasaki disease? The answer is, it depends on the clinical manifestation. About some manifestation is common with Kawasaki disease, and some is more frequent with MIC than Kawasaki disease. So the common with Kawasaki disease is, again, fever, rash, conjunctival injection, cervical adenopathy, lip and oral changes, swollen hands and feet, and irritability. The other clinical manifestation, it's not common with Kawasaki, but it's more frequent in MIC. They have diarrhea, meningeal sign, myocarditis, MAS, macrophage activation syndrome, which can be seen in 1 to 2% in Kawasaki disease, and it can be seen in 20 to 30% in patients in MIC. Clinical manifestation can be seen in MIC, but we cannot see it in Kawasaki disease. Mainly, as we mentioned it, lymphopenia, relative thrombocytopenia, with the exception if there is macrophage activation syndrome or toxic shock syndrome. Next. So this is just to compare Kawasaki disease and MIC. So I will highlight mainly about the MIC, which is main presentation is around 7 to 8 years. As we mentioned it, the median age is 10 years. And they have more mainly of gastrointestinal manifestation, including nausea, vomiting, and diarrhea. Cardiac dysfunction, it have more common manifestation than in Kawasaki disease, coagulopathy and shock, as well as macrophage activation syndrome. So all these symptoms is more prominent in MIC than Kawasaki disease. The ethnicity is more in Asian Kawasaki disease, but more in Afro-Caribbean patients with MIC. Next. Since we already talked about the cardiac involvement, so the most important cardiac investigation need to be done during MIEC since it's more common to have cardiac manifestation. So brain nitropruritide should be done at the time of diagnosis for all patients. Serum troponin level should be done at the time of diagnosis as well. And in hospitalized and severe clinically ill patients, ECG should be done every 48 hours, and echo should be done at diagnosis, and during a clinical fellowship during hospitalization should be repeated at 7 to 14 days if there is cardiac abnormalities, and at 4 to 6 weeks for follow-up. Cardiac MRI should be done at 2 to 6 months after the diagnosis, and if we suspected distal coronary artery aneurysm, cardiac CT should be obtained. Next. So now we'll talk about the management of MIEC, including the ACR guidelines. So if we have a mild symptoms, close monitoring without immunomodulatory treatment could be enough. Empirical use of IVIG can be used to prevent coronary artery aneurysm as well. So indefinite symptom of MIEC, high dose of IVIG, 1 to 2 grams per kg, low to moderate dose of steroid, and cardiac function fluid status should be assessed clearly before giving IVIG. Next. In life-threatening complication, so high dose or pulse steroid is very important. In MIEC refractory to steroid or IVIG, we should consider interleukin-1, anakinra. Anterior lab test and cardiac assessment should guide the immunomodulatory treatment response and tapering, and usually the tapering will require 2 to 3 weeks. Next. So this is just, it was mentioned in the ACR conference as the management of MISC modalities, as we can see it in different studies. So, and we talked about it already. So like I will concentrate mainly about the Feldstein, which is the 77% from them, they used IVIG, around 49% they used steroid, and 13% used anakinra. Few studies, only around 8%, they used tocilizumab as well and infliximab. Next. So, any questions?
السلام عليكم ورحمة الله وبركاته دكتور آدم.
وعليكم السلام ورحمة الله.
I'm still listening to your talk from the other computer.
Okay, sure.
Okay, once we finish, you almost finished.
Okay, sure, Doctor. Take your time.
Okay, thank you very much, Dr. Ghada, for this excellent review of MIS-C Kawasaki and multiple inflammatory syndrome. Actually, the new syndromes or all syndromes Kawasaki disease, and you have clearly differentiated between all three of them. And thank you very much for this nice talk. I'm waiting for question answer from the audience. Over until somebody asks a question, we can start. So what's your experience in case for, I mean, what's your advice to the general pediatrician if they saw cases with fever, gastroenteritis, when they should suspect MIS-C or multiple inflammatory syndrome in the absence of cardiac involvement and absence of persistent fever?
Doctor, what did you say about the cardiac involvement?
I mean, what is your advice to general pediatrician if they see a patient with fever or low-grade fever, subjective fever with gastroenteritis? How they can take it lightly, or how they can differentiate between these syndromes and simple gastroenteritis?
Okay. So yeah, it's a good question actually. So as we mentioned, there is some similarity between Kawasaki disease and multisystem inflammatory. So if I exclude Kawasaki disease, for example, in a patient who presented with fever and skin manifestation or GI manifestation, nowadays MIC should be considered in the first differential diagnosis. So all the labs should be obtained, including the CBC and differential, the most important inflammatory marker, C-reactive protein, and ESR, and procalcitonin as well, plus the renal function, and including the serum albumin, plus including echo. Actually, to be honest, the cardiac management or the cardiac investigation, it depends on the clinical manifestation. So if I am suspected multisystem inflammatory syndromes, so nowadays they are doing even enzyme troponin. So it should be done in the time of diagnosis, and the PMP also should be done. If there is some cardiac manifestation, echo should be done in, initially at the presentation, and ECG as well if the patient is severely and clinically ill, and it should be done regular, like every 48 hours until the patient is stabilized.
Okay, there is a question from one of the audience asking how long aspirin should be used.
How long what?
How long aspirin should be used in case of MESI?
Actually, all of the studies we are talking about the management, it depends on the severity. So if the patient is severely ill, so the first thing should be started with IVIG, but we have to make sure that the cardiac function is stabilized and the fluid management is already obtained. This is number one. The second one is methylprednisolone, and as well it depends on the severity. So aspirin usually depends cardiac manifestation and depend on the severity of cardiac manifestation. Like if I'm suspecting Kawasaki disease, this is different. So I'll just follow the protocol of Kawasaki disease and using the aspirin until I have normalized echo. So the main management, I mentioned it in MESI, it's mainly IVIG, methylprednisolone, fluid management, and also we have to consider IL-1 sometimes in refractory cases.
You mean once they recover, no need to give aspirin for MESI?
If there is cardiac manifestation, yes, we need to give.
And then the question for how long you will use aspirin?
Actually, we have to do the echo seriously, like around 4 to 6 weeks. This is the first time. And then after that at 6 to 8 weeks. And then after that at 8 to 12 weeks. So depend on the echo. As long as the echo there is abnormality, we should continue on aspirin.
Okay. So aspirin used until the cardiac muscle disappear or inflammatory marker back to normal?
Yeah, most likely.
Okay. Another question is there a specific number of doses of IVIG before I can consider a refractory to IVIG?
No, we are starting with the regular, all the studies, they started with the regular dose, 1 to 2 grams per kg. And it should be, and after that, they should go to the second line.
So after second, you have to give third dose or you consider refractory and you start something else?
No, usually they give like sometimes up to 3 doses, and then after that, if there is no response, they should start with methylprednisolone pulse therapy, 30 milligrams.
You can go up to 3 doses of IVIG, and if after that you consider this refractory if there is no response.
Yeah.
Okay. Another question: can patients with MESI presented as late manifestation as 1 month later with full case definition criteria?
Sorry, doctor, the question again, please.
Okay. The question said that can patient with MESI presented as late manifestation as 1 month later with full case definition criteria?
They can, but most of these cases, they will not have a positive PCR or antigen test of COVID-19.
So they can present after 1 month later from the infection, or is unlikely they should be present within, what is the duration period where they present after infection? The question, how long it takes after infection for the disease to appear, manifest? Is it 1 week, 2 weeks, or 1 month? After 1 month can the symptoms appear again?
The third thing is sometimes a patient, they only have positive antibody, which can be positive within 4 weeks after the previous infection. So yeah, up to 1 month we can diagnose.
Okay. It's excellent presentation, Doctor, and I think there is a lot of similarity between these 3 syndromes, MESI, Kawasaki, and multiple inflammatory syndrome, pediatric PIMS. And I think it's you need high index of suspicion, and all patients, I think, need to be admitted and work for cardiac involvement. Okay, Dr. Ghada, I have a question or more questions.
Yeah.
In severe case of MIS-C, use enoxaparin and then aspirin. When the condition stabilize, this according to protocol, do you think?
I didn't go across any use of enoxaparin actually in the articles that I have been go across, but aspirin, yeah, they have been used in severe cases of cardiac manifestation.
In adult, maybe. In pediatric, we do not use enoxaparin here. You are right.
Yeah, it have been used in adult, yes.
Okay.
As we know that adult, they have more severe manifestation and more respiratory involvement than in pediatric.
And more risk of DVT in case of immobilization.
Exactly, yeah. And
Like
more
children. So
cardiac.
really, we use enoxaparin. I totally agree with you. Okay. Okay, for the time being, we do not have more questions, but what is your last message to general pediatrician nowadays when we see cases of pediatric with fever and skin rash?
Nowadays, with this pandemic that we had, so any patient, he came with unexplained cause of fever, especially pediatric age group, in the children, even younger infant or more than around 10 years of age. So any unexplained fever, skin manifestation and GI manifestation, if COVID PCR or antigen is negative, so antibodies should be done, and MIC should be taken in consideration seriously, and management should be started and not delay the management. And don't forget to do the cardiac investigation like echo and at least serial ECG.
Okay, thank you very much for this excellent talk and review, and wish you a good weekend. Thank you very much.
Thank you so much, Doctor.
Now, can I introduce, am I online? Can I introduce the third speaker?
Yes, doctor.
Okay, our third speaker is Dr. Rohud Al-Ahmed. She is a pediatric rheumatologist. She is recently graduated from Pediatric Rheumatology Fellowship at Nationwide Children's Hospital in Columbus, Ohio, United States of America. Dr. Al-Ahmed was involved in various clinical researches and has a particular interest in quality and patient safety. Dr. Al-Ahmed is going to talk about new vasculitis in childhood and new scleroderma. Dr. Al-Ahmed, please start.
Hello, my name is Rohud Al-Ahmed. I'm a pediatric rheumatologist at King Abdullah bin Abdulaziz University Hospital in Riyadh. First, I would like to thank the organizing committee for the invite. I have no disclosures. The majority of my slides were adapted from presentations given at ACR 2020 by these authors. Starting with updates in vasculitis, I will cover the updates in Takayasu arteritis, Kawasaki disease, IgA vasculitis, and monogenic vasculitides. In the past few years, there have been exciting advances in Takayasu arteritis concerning pathogenesis, clinical presentation, treatment, disease monitoring, and outcome. We will directly start with pathogenesis. One of the most exciting discoveries in the pathogenesis of Takayasu arteritis is the critical role of the JAK-STAT pathway, which is the principal signaling mechanism for a wide array of cytokines and growth factors. Recent studies found an upregulation of type 1 specific interferon gene signature in Takayasu arteritis patients compared to healthy controls, as you can see here with the red bars. They also found in a mouse model that treatment with JAK inhibitors, tofacitinib, showed a significant reduction in vascular inflammation. Another pathway of inflammation in the pathophysiology of Takayasu arteritis is the mechanistic target of rapamycin complex 1, or mTOR-C1. mTOR is a kinase that critically regulates T cell differentiation, proliferation, and metabolism. A recently reported study found that mTOR-C1 is hyperactivated in CD4 cells from Takayasu arteritis patients compared to healthy controls and compared to patients with small vessel vasculitis, in this case GPA, and that blockade of mTOR-C1 activity in a mouse model reverts its effect. More recently, Takayasu arthritis was described in patients with primary immunodeficiencies caused by mutations in NOD2, STAT1 gain of function, and XTAP. So one should consider monogenic causes of Takayasu arthritis in case of early disease onset, association with other autoimmune disease such as inflammatory bowel disease, or a presence of features suggestive of a primary immunodeficiency. Lastly, a recent Japanese study identified two major endothelial autoantigens and their corresponding autoantibodies, highlighting the role of acquired immunity in the pathogenesis of Takayasu arthritis. In the core features and disease outcomes, although the clinical presentation of Takayasu arthritis is often nonspecific, a recent large cohort confirmed that arterial hypertension is the most common presentation in children, along with signs of decreased vascular perfusion, such as decreased pulses, bruise of large arteries, or blood pressure discrepancy, highlighting the importance of thorough physical exam, particularly in a child with unexplained systemic inflammation. Regarding morbidity and mortality, the studies were very heterogeneous, but overall, it seems that the outcome is getting better, possibly due to earlier recognition or better treatment options. There have been efforts to compare children and adults with Takayasu arthritis, and here are some specific differences between the two groups. Children have a lower female predominance, they have shorter diagnostic delay, they have more common involvement of the aorta and renal arteries, and subsequently, they present more frequently with arterial hypertension. In contrast, adult patients have more frequent involvement of the upper extremity vessels, and they more commonly have arthritis and arthralgia. Generally, the differences are suggestive of a more severe disease in children, which needs to be confirmed. Regarding new therapies, the beneficial effects of using TNF and IL-6 inhibitors in the treatment of Takayasu arthritis are known in the literature, but there is interesting conflict of results. A retrospective cohort of 27 patients on biologics, mostly TNF inhibitors and some on tocilizumab, showed that those on biologics, represented by the black line on the figure, had better flare-free survival compared with conventional DMARDs or corticosteroids alone. In addition, the use of anti-TNF and tocilizumab on a case-to-case basis was included in the recent European consensus-based recommendations for the treatment of childhood vasculitis. Surprisingly, when tocilizumab was compared to placebo in a randomized controlled trial of mainly adult patients, those who received tocilizumab tended to have less relapses, but there was no significant difference compared to placebo. On the other hand, undesirable results exist. While some studies reported patients that were primary non-responders, others reported patients who developed Takayasu arthritis while being treated with anti-TNF for another disease. Today, there are only 14 reported Takayasu arthritis patients who were treated with JAK inhibitors, most frequently tofacitinib. 3 of them were less than 18 years old. The response was overall good. However, there were few primary non-responders as well, but of course, more studies are needed to better assess their effect. It is worth to mention that abatacept was found not superior to placebo in a recent randomized controlled trial, and there are uncontrolled studies about other agents, including ustekinumab and rituximab, that have been used for refractory Takayasu arthritis without high level of evidence for their use yet. And for disease monitoring, we cannot underestimate the challenges one would face when treating a patient with Takayasu arthritis. To date, there are no disease activity measure that reliably reflects vascular inflammation. Although the pediatric vasculitis activity score has been validated in children, it is not the optimal tool for those with large vessel vasculitis. Imaging is essential at the time of Takayasu arthritis diagnosis. However, studies reported that around half of the patients who were considered to be in clinical remission had imaging with MR angiography or PET scan that was interpreted as active vasculitis. Additionally, histology could detect subclinical vasculitis in patients who were presumed to be in remission. Moreover, there is a lack of reliable biomarkers. However, some reports suggested that longitudinal monitoring of IL-6 levels during follow-up may be useful for assessing disease activity and detecting infections, especially when tocilizumab is being used. In Kawasaki disease, I will cover updates related to treatment, complications, and long-term outcomes. Starting with the treatment, in an attempt to identify the best second-line treatment for IVIG refractory Kawasaki disease patients, a systematic review paper of 8 studies that included over 300 patients found that patients who received infliximab showed the best response in terms of resolution of fever at 88%, compared to a second dose of IVIG or IV methylprednisolone. However, there was no difference in coronary outcomes. Now, this is a very interesting study about how much aspirin is really needed. In a systematic review of 8 retrospective studies that included over 12,000 patients, authors compared low-dose aspirin, that is less than 10 milligrams per kilogram per day, to high dose. They found that patients on high-dose aspirin had slightly faster resolution of fever. Otherwise, the duration of hospital stay, rate of IVIG resistance, and risk for coronary disease were no different. In another study, no increase in fever recurrence rate among Kawasaki disease patients treated with low-dose aspirin was noted. Although these results came from retrospective studies, they are still worthy consideration given the potential toxicity of high-dose aspirin on children. Now we'll move on to Kawasaki disease complications, specifically Kawasaki disease shock syndrome. In this single-center retrospective study, they described 18 patients with Kawasaki disease shock syndrome predating the COVID-19 pandemic. The median age was 3.9 years. Most patients had less than 10 days of fever, and half of the patients were admitted to the pediatric ICU prior to day 5 of fever. The median ferritin level was just above 200. In regards to cardiac outcomes, half of the patients received fluid boluses. Around 40% received inotropic support. 1 patient required ECMO, and another patient was kept under observation. And for coronary involvement, 22% of the patients had a Z-score of more than 2.5 on the first echo, and the number of affected patients gradually declined in the subsequent echoes, concluding that the prognosis of a pre-pandemic Kawasaki disease shock syndrome is generally good with good coronary outcomes. Moving to long-term outcomes, there are 2 studies that were conducted on the same cohort of Kawasaki disease patients in Canada. One described delayed cardiovascular outcomes, and the other one looked at the neurodevelopmental outcomes. They identified 4,597 patients with Kawasaki disease, and each patient was matched to 100 non-exposed children. Kawasaki disease patients were followed from the point of hospital discharge for a median of 11 years, but up to 24 years after their initial illness. Regarding late cardiovascular outcomes, authors found that Kawasaki disease survivors have an increased risk of cardiovascular events that may continue for more than 10 years after their initial diagnosis, and that patients without initial coronary involvement were also found at increased risk for cardiac events compared to non-exposed children. And this is very important because most Kawasaki disease patients without coronary involvement are likely to be discharged from pediatric cardiology follow-up within few months from their diagnosis. They also found that the risk for all outcomes was highest in the first year and subsequently decreased. Interestingly, despite the higher risk of cardiovascular events in Kawasaki disease survivors, the risk of death was lower compared to non-exposed children. The causes will be further elaborated in the author's future directions. Concerning the long-term neurodevelopmental outcomes in Kawasaki disease patients, the authors found that hearing loss, anxiety, ADHD, and intellectual and developmental disorders were more common among Kawasaki disease survivors than matched comparators throughout follow-up, because these differences may impact a child's future academic performance and social functioning. Enhanced developmental and audiological surveillance is therefore warranted for these children. Now we will go over updates in IgA vasculitis, specifically HSP nephritis classification. In this cross-sectional study of 69 patients with HSP nephritis, the authors compared the 4 most commonly used histological classification for HSP nephritis in order to determine the best predictor of disease outcome. They concluded that the modified semi-quantitative classification has the strongest association with the severity and outcome of HSP nephritis, followed by the Oxford classification, and that the tubule interstitial changes could be more important than crescents as poor outcome predictors on renal biopsy. In monogenic vasculitides, I will briefly talk about deficiency of ADA2 or DADA2, haploinsufficiency of A20 or HA20, sting-associated vasculopathy with onset in infancy or SAVI, and some immunodeficiencies. I will be focusing on the similarities between these specific conditions and the classical systemic vasculitis disorders. Patients with DADA2 may present with features that mimic classical polyarteritis nodosa or PAN. Of the involved systems, almost all of DADA2 patients have a skin involvement in form of livedoreticularis, nodosal lesions, or ulcers. They could also have necrotizing vasculitis on tissue biopsies, and they could present with aneurysms, which both might be undifferentiated from classical PAN. So how to differentiate DADA2 from classical PAN? Given that DADA2 has an autosomal recessive inheritance, a positive history of consanguinity or affected family members is likely present. Red flags may include stroke, cytopenias, and low immunoglobulin levels. Important biomarkers are ADA2 levels and platelets counts. Patients with a classical PAN had very high platelet counts, more than 450,000, compared to the much lower numbers in DADA2 with a significant p-value. And the definite diagnosis will be through genomics. Another monogenic cause of vasculitis is the HAT20. These patients could mimic Behçet's disease with a very similar GI vasculitis and ulcers. This study compared the two conditions and highlighted the major differences, which are summarized in this table. We can see here that HAT20 is inherited in an autosomal dominant route, and so patients will have early disease onset. Unlike Behçet's disease, patients with HAT20 will have fluctuating autoantibodies, including low titers of ANA, anti-double-stranded DNA, and anti-Smith RNP antibodies. Moving on to SAVI. SAVI disorder could resemble vasculitis in that patients may present with skin ulcers or nodules affecting various parts of the body and leading to acral necrosis and tissue loss. Additionally, there is skin biopsy, which show leukocytoclastic vasculitis and microthrombotic angiopathy of small dermal vessels. There are a number of immunodeficiencies that might mimic vasculitis. This is a very nice review that listed gene defects with corresponding phenotypes under each immunodeficiency category. Here, I would like to draw your attention to the red circle at the top, highlighting RAG1 defect, which could mimic PAN, and ZAP70 defect that could mimic ANCA-associated vasculitis. So we should consider monogenic vasculitis when there is a suggestive family history, clinical or lab features that are inconsistent with our initial diagnosis or that are suggestive of immunodeficiency disorder, and if there is no or inappropriate response to the conventional treatment of our diagnosis. To summarize, in Takayasu arteritis, newly discovered pathogenesis pathways include the JAK-STAT signaling pathway, the mTORC1 hyperactivity, and monogenic causes. The most common clinical feature in children is arterial hypertension, and thorough physical exam is very important in a child with unexplained systemic inflammation. Potential targeted treatments in children include anti-TNF, IL-6 inhibitors, and JAK inhibitors. And we also reviewed the challenges in disease assessment during follow-up and that longitudinal IL-6 levels is a potential biomarker. In Kawasaki disease, infliximab is a good option as a second-line agent for IVIG refractory Kawasaki disease cases. Low-dose aspirin is as effective as the high dose in acute management. The prognosis of a pre-pandemic Kawasaki disease shock syndrome is generally good. There is an increased risk for late cardiovascular events in Kawasaki disease survivors, even in patients without initial coronary involvement, and Kawasaki disease patients are at increased risk for long-term neurodevelopmental disorders. In IgA vasculitis, the modified semi-quantitative classification of HSP nephritis has the strongest association with disease activity and outcome. And in monogenic vasculitides, we highlighted that DATA2 could mimic PAN, HA20 could mimic Behçet's disease, and SAVI and some immunodeficiencies could have vasculitis-like presentation. We then reviewed the conditions when monogenic vasculitis should be considered. Now we're switching gears to the second part of my talk, that is updates in juvenile scleroderma, divided into localized scleroderma and systemic sclerosis. In localized scleroderma, we will cover what is new in genetics, treatment, and disease monitoring. Starting with genetics, using transcriptome analysis of JLS or juvenile localized scleroderma skin biopsies, the authors of this study identified two distinct JLS groupings, inflammatory-related pathways and fibrosis-related pathways. However, these immune phenotype groups did not directly correspond with the patient's clinical phenotype. Moving on to the treatment, the next two papers are about the consensus treatment plans or CTPs for JLS developed by KERA and were first published in 2012. The next two papers are about the consensus treatment plans or CTPs of juvenile localized scleroderma or JLS developed by KERA and were first published in 2012. These are three methotrexate-based CTPs. First option is methotrexate monotherapy in blue. Second option is methotrexate with IV methylprednisolone for 3 months. And the third option is methotrexate with daily oral steroids in green. In the first paper, the authors reported the results of a pilot study examining the clinical outcome of 50 patients with JLS who were treated according to these CTPs. And they found that improvement was observed in all three groups, with over 75% demonstrating major or moderate improvement. The second paper is a retrospective single-site study of 61 JLS patients, where the authors assessed the impact of these CTPs on their practice. They found a significant jump up from 8 to 78% of their patients who had received treatment that matched one of these three CTPs. In addition, the need for second-line agent was lower among patients who had received the treatment according to any one of the CTPs. Now, this is a recently published multi-center retrospective study that evaluated the use of abatacept in 18 JLS patients who failed the standard of care, which is methotrexate with or without glucocorticoids. All of the patients received concomitant DMARDs, most frequently methotrexate or MMF, and 70% received glucocorticoids at the start of abatacept. Both skin and musculoskeletal activity improved with abatacept. In the figure on the left, we see the physician global assessment or PGA for disease activity and the skin activity scores declining from 0 to 12 months and then remaining stable from 12 to 24 months. In contrast, the PGA for disease damage did not change over time. Musculoskeletal activity on the right also improved with arthritis resolving in 3 of 4 patients, arthralgia in 4 of 8 patients, and all 7 patients with muscle activity. Many patients discontinued concomitant treatment. DMARDs was discontinued in about a quarter of patients and glucocorticoids in 60% of patients. None of the patients was rated as worsened and there were no serious adverse events. 3 patients who dropped out for adverse events, either mood changes or pregnancy. Overall, there were 4 treatment failures, with the 3 of the patients remaining on abatacept, but receiving additional treatment with glucocorticoids or MMF, and 1 patient switched to tocilizumab. In conclusion, in refractory JLS patients, abatacept was found to be safe in combination with other DMARDs and effective, with improvement noticed in skin and musculoskeletal activity and a significant reduction in the need for other medications. Now we will move on to disease monitoring. In this study, the KERA localized scleroderma work group developed a localized scleroderma cutaneous activity measure, or LSCAM, to overcome the limitations noticed in the modified localized scleroderma skin activity index, or MLOC, in regards to its ability to detect small changes in activity level. The level of inter-rater reliability scoring for LSCAM was similar to that found for MLOC and for PGA for disease activity. LSCAM also appeared to be more closely resembling PGA for disease activity with a strong to very strong correlation than did MLOC. In conclusion, LSCAM is a new localized scleroderma connectivity measure that was found to be reliable and valid for monitoring JLS disease activity. The total morbidity score, or TMS, was also developed by KRA localized scleroderma work group to capture the full spectrum of disease morbidity. The authors in this study reported their evaluation of TMS performance on 48 patients. They found that TMS was of a strong construct validity with PGA for disease damage, and the values were higher than those found for skin-only damage measure. These findings suggest that TMS will aid monitoring of disease status and treatment response. In this pilot study, the authors explored the use of von Willebrand factor as a biomarker in juvenile scleroderma. A total of 24 patients with juvenile scleroderma were included. Half of them was systemic sclerosis. They found a negative trend in von Willebrand factor antigen levels over time for both groups. Patients with systemic sclerosis had higher and more chronically elevated levels compared to those with localized disease. Independent predictors of von Willebrand factor antigen included disease severity, skin ulcers, exposure to DMARDs, and non-Hispanic ethnicity. Neither level of ESR or CRP, nor the disease type or duration, or the capillary nail bed abnormalities were independent predictors. Last but not least, I will go over 3 studies that addressed issues related to juvenile systemic sclerosis. In this case series of 6 patients with juvenile systemic sclerosis, sinus scleroderma, which I will refer to sinus scleroderma, the aim was to highlight cardiovascular involvement as a clue for this diagnosis. The incidence of sinus scleroderma was 8% of their cohort. In this group, the majority had positive ANA and scleroderma-specific antibodies. All had cardiovascular involvement as a presenting feature, 3 with a primary myocarditis and 3 with secondary pulmonary hypertension. None of the patients fulfilled either the adult or pediatric criteria at diagnosis. When compared to classical systemic sclerosis patients, the prevalence of heart involvement in sinus scleroderma group was significantly higher, 100% versus 16%. In conclusion, this is the first case series of patients with juvenile systemic sclerosis, sinus scleroderma. Cardiovascular involvement represents the most important clinical feature and carries a very high morbidity and mortality rate. The findings confirm the crucial role of targeted autoantibody and capillaroscopy check in pediatric patients with isolated myocardiopathy or pulmonary hypertension. The next 2 studies use the same cohort of juvenile systemic sclerosis that is considered to be the largest prospective international cohort of patients with this disease. The first study addressed the screening for interstitial lung disease, or ILD, in systemic sclerosis patients by comparing the results of FVC from pulmonary function test to high-resolution CT imaging. DLCO readings were also captured, but not too many patients. They found that the sensitivity of FVC in detecting ILD was only 39%, meaning that relying on the PFTs alone to screen for ILD in systemic sclerosis patients would have missed ILD in almost 2/3 of the patients, supporting the use of high-resolution CT in this group of patients. They also suggested that the cutoff utilized of less than 80% of a predicted FVC or DLCO could be too low for pediatric patients to exclude beginning ILD. Using the same cohort, this study looked at patient and physician-related outcomes and the pattern of organ involvement in the long term. At 36-month follow-up, the disease activity score of both patient and physician decreased, as well as the disease damage score of the patient, but not the physician. Also, looking at the pattern of organ involvement, near-fold capillary changes was the only one that had increased during follow-up. In conclusion, after 36 months of follow-up, patients with juvenile systemic sclerosis could show a significant improvement in patient-related outcomes and only one significant change in organ pattern involvement. To summarize the updates in scleroderma that we've covered, in localized scleroderma, there are 2 distinct pathways of JLS identified by RNA sequencing. KRA CTPs are effective in a pilot study and they change the treatment practices. Abatacept is a treatment option for refractory cases of JLS. The ILSCAN is a reliable and valid scan activity score, and the TMS captures a range of morbidities in JLS, which will aid in disease monitoring. Von Willebrand factor antigen is a potential biomarker for both localized and systemic types of juvenile scleroderma. In systemic sclerosis, cardiovascular disease is an important presenting feature of sinus scleroderma subtype, and that PFTs could miss 2/3 of ILD in systemic sclerosis patients. Finally, after 36 months of follow-up, patients with systemic sclerosis had improved patient-related outcomes. By this, I finish my talk. Thank you for listening, and I will be happy to answer your questions.
Thank you very much, Dr. Ahoud, for this nice, excellent review for these two most difficult topics, vasculitis and scleroderma. I enjoyed your topics, especially the new recommendations and follow-up and advanced biomarkers, genetics studies, and treatment. I have many patients with scleroderma. I'm waiting some questions from public. And the first question from public, there is a question from one of our colleagues. What was the protocol treatment for abatacept in patients with morphia?
They used the JIA dosing of abatacept.
Okay, like induction therapy, 8 milligram or 12 milligram below 30 kilos, like?
Yes, yes.
With 2 weeks apart, and then every month.
Exactly.
Was there any side effect for these medications during infusion?
According to the authors, there was no major side effect, but there was 3 patients who developed a site infusion reaction and site infection, injection site infection.
Okay.
But nothing major.
Did you use IV or sub-Q?
They use sub-Q.
Sub-Q. Do you know the dose? What was the dose they used? Because
I
IV
can't
have difference.
Yeah, I'm not quite sure at the moment. I can look that up for you and get back to you.
Did you come across interleukin 6 in the management of scleroderma?
Not that I'm aware of.
Okay. Another question, following the dose of affected area back to normal or improvement was limited to arrest the disease progress.
Can you repeat the question, please?
Yeah. They're asking when to stop therapy in localized scleroderma after disease control.
I think that there is a controversy in this specific situation. What I have been seeing and what I have experienced during my fellowship, that the majority of the pediatric rheumatologists would discontinue the treatment gradually after 2 years from no disease activity.
Okay. So if you face the case of scleroderma, there are 3 arms of treatment. One is just DMARD, one is with the steroid, one is... So which one you will prefer from your review?
I can't really tell because from the results that they found, that the authors concluded that all of the 3 arms had showed improvement. There was just being on a plan that matched one of the 3 CTPs was enough to show improvement, and not specifically, not exactly one of them. Just being on a CTP plan would show improvement.
Any one of them, any one of the arm has more side effect than others? If the improvement is same, what about the side effect? Which arm are more side effect dealing with the improvement?
I would assume that the arm with daily oral steroid might be the one that would show more adverse effects. But I think a prospective study that it's controlled would give us the more accurate answer.
Okay. Another questions. They said in patients with juvenile scleroderma progressive with pansclerotic type as an initial presentation, treatment, do you prefer to use methotrexate with cyclosporin or abatacept?
Methotrexate with abatacept or methotrexate with cyclosporin. Yeah. I actually don't have a good answer for this. I think a good literature review to compare and look if the two approaches had been used or compared would be better.
Yeah, it's very difficult to monitor the disease activity in scleroderma. However, you can go clinically by active skin lesions or by biomarkers, mainly inflammatory markers. In my experience, we use the methotrexate and a steroid as an initial treatment, followed if there is intolerance to methotrexate, we add cyclosporine or cyclosporine A. We rarely use cyclophosphamide. However, we don't have abatacept in our center, so some studies say that interleukin-6 may be helpful. And we use in one patient interleukin-6, and we have excellent response with that, especially in the linear scleroderma, not only morphia.
That's good to know. Thank you for sharing.
Yeah, I did not face any progressive scleroderma in my practice until now, thank God, because one of the most difficult cases to treat.
Of course.
Do you think after this review, do you change your practice in management of some cases? Or still you go to conventional therapy, or you start by biologics immediately?
Well, I think I will go with a combined treatment from the beginning. Yeah.
Okay. I'm just waiting some more questions, but I think that was the last questions. Just let me ask you one more question. In case of scleroderma, sometimes we face severe skin involvement with no significant involvement. Do you think cyclophosphamide, we can go back to conventional therapy before, maybe as an option in case of resistance, or in case of you don't have in your center biologics?
For just a skin disease, I'm not quite sure. I think it is used more often for an internal organ involvement, like interstitial lung disease, but I can't really tell if it's for just a skin disease.
Okay. Do you have any message to the audience how to take care of these patients in future regarding this activity?
Which disease of them? I went through a lot.
I mean, very rare to see scleroderma, like in one case every 5 to 6 years. Like, however, vasculitis, we see a lot of vasculitis. The one which is monogenic disease, what will be your advice to them? Because most of these cases diagnosed genetically by genetic tests. However, we can suspect some of the disease with early involvement of skin and inflammatory marker, high fever. So what will be advice to patients with suspected like immune deficiency and vasculitis?
Of course, to keep in mind and to have a high index of suspicion whenever your patient is not responding to the conventional treatment, or not going through the right track as you would expect, or if you've noticed there is an abnormal or atypical clinical features, lab findings, or if the family history is suggestive, just a good full history and physical exam going back to the basics would actually help direct to the right diagnosis.
Early refer to pediatric rheumatologist if you suspect any underlying vasculitis, right?
Of course. Okay. And get immunology involved if you don't have a pediatric rheumatologist.
Yeah, exactly. The multidisciplinary approach, so we can share with our colleagues in our to reach appropriate diagnosis. Well, thank you very much for this excellent topics and excellent review. I congratulate you.
Thanks for having me.
Thank you very much.
Thank you.
By this, we'll come to the end of our topics, and I wish to the audience for a nice weekend. And I appreciate if all audience can fill the survey, please. Do not forget to, at the end of our topics, please fill the survey and send it as soon as possible. And we highly appreciate your cooperation. Thank you very much. I'd like to thank Dr. Hanan Reyes and Dr. Ashwag and Prof. Suleiman for this nice topics selections and excellent speakers. and hope we can arrange more conferences in future. And thank you for organizing committee, and thank you for Mr. James and all technical IT team. Thank you very much.